Good evening all. On behalf of MahaIP, I, Dr. Kundan Chopde, welcome you all on this auspicious occasion of Nag Panchami for this sixth session of Protocols in Pediatric Practice. This is conducted on second Friday each month under Presidential Action of Plan of Visionary Dr. Ram Gopal Sir. This is one of the well appreciated and well sought program on our MahaIP platform, where we bring together experts in pediatrics and they guide us through the essential protocols, and we compare various protocols and give practical guidelines to practicing pediatricians. So the protocols are not limited to critical care. They are relevant in other clinical situations also. So hence we have selected common topic which is faced by all pediatricians in their day-to-day practice, that is constipation. And to enlighten on this, we have excellent expert Dr. Vishnu Birajdar, who is eminent pediatric gastroenterologist from Pune. I will request Dr. Ram Gopal Sir, our dynamic MahaIP president, to give few words of wisdom. Unmute, sir.
Sir, kindly unmute.
Yeah, thank you, Kundan. Good evening, everyone. Good evening, friends. As the name of the title, our program says, Protocols in Pediatrics. Already Kundan has told you. The protocols are not only for the emergencies, even for the routine cases, we need certain guidelines. Or I can say it is a guideline or a protocol. Both are synonymous. So we have to follow certain guidelines, and for that we always requires a topic which is day to day. Now constipation, I think it's a bread and butter day to day topic, and for that we also we need guidelines. Sometimes the constipation also becomes a headache for us. Every time the parents come, kuch nahi ho raha hai, doctor sahab kuch nahi ho raha hai. So for that, today I welcome Dr. Vishnu Birajdar. Sir, he is a gastroenterologist. Welcome, sir.
Thank you.
And
Thank
without taking much time, I think everyone is waiting for the signs. So Kundan, over to you.
Yes, I will request your smiling, energetic Dr. Amal Pawar sir to say a few words.
Yes, Kundan, one more thing. Now, Amol,
Yes,
Amol,
sir.
even our EB Dr. Jitendra Gawane has joined.
Yes.
So after Amol, I
Yes.
will request
Yes,
him to say one word, few words.
Yes, sir. Yes, sir. Yes, sir.
No,
So,
don't
thank
reduce
you.
Vishnu's time by Bhashan Baji.
No, only 1 minute. Okay, Amol,
Yes,
start.
thank you, Dr. Kundan. Already Ram sir has explained the idea behind this webinars. This is all Maharashtra IIP is for all Maharashtra IIP members and all the national IIP members also. So this time Dr. Vishnu is there. He's contributing a lot for national IIP also. Just last month only, we have launched a module on pediatric gut health, and he was there in Jaipur. He is the core faculty member, writing member of that module, and there are various programs under Presidential Action Plan. So this is one of them, and this is very important as everybody gets to know all the protocols designed for various diseases, and they are helpful to all the general pediatricians also in their office practice. So once again, I wish all the delegates happy learning and hand over mic to Dr. Jitendra Gawane, Executive Board member from MMR region. Yes.
Yeah. So good evening, everyone. Today feels like RM Bhatt's reunion with Kundan and Vishnu and me together on this platform. Very practical topics were chosen by Amol and Ram Gopal for practicing pediatricians, like day-to-day from the day-to-day problems like constipation from the experts in the field. And when Vishnu started pediatric gastro clinic in our area, that time he told he's keeping the registry for constipation patients. So I was wondering, for constipation also we have to keep registry, and he brought out one paper out of that. So amazing, Vishnu. So we want to know practical approach, how many days to give medication or just disimpaction is sufficient. So let us hear from you, Vishnu.
Yes, thank you, sir. I also welcome all EBs and OBs of MahaIP for joining this webinar. When we selected the topic, the obvious name for expert was Dr. Vishnu Birajdar. When I approached him, as Amol told, he was busy as a chief scientific advisor for this gut module, gut GPT, and he was in Jaipur. So he also told me that he has to conduct online this TOT on 6th and 7th August. So as I have insisted him, he is being my senior and good friend. As Jitendra sir said, we are together at GMC Mumbai JJ Hospital and in a hostel. So itna to hak banta hai. I insisted him, and today he is here as an expert. Thanks, Vishnu, for accepting our invitation as a MahaIP invitation. And over to you. Just I will introduce Vishnu Bilasdar. He has done his MD and PDGC and fellowship in pediatric liver transplant from UK. His present designation is he is consultant pediatric gastroenterologist and hepatologist and affiliated to Ruby Hall Clinic, Pune. And he is having his own Kamal Endoscopic Center at Shivaji Nagar, Pune. His major achievements are his ISPAGAN International Travel Exchange Award, got award in 2018 and 19. And he has many papers, poster, and publications in national and international platform. And now he is as chief scientific advisor for GUT GPT module in Central IIP. Just a quick reminder before I pass proceedings to Vishnu. For all delegates, if you have any questions, please feel free to post in chat box. So at the end of the session, we make sure that we will address all these questions from our expert, Dr. Vishnu Birazdar. Over to you, Vishnu.
Thank you, thank you. I'm delighted and very excited that fortunately I took my ragging has been done by Jitendra and I did ragging on Kundan. So, so with this, I think the constipation is day-to-day topic, and we all face problems when we address this issue.
Vaccine.
Vaccine.
So what I have done is like this module the topic needs the protocols, because I'm not talking about what my experience is. I'm not talking about what has been taught to us or what is discussed in the various forums, but what is there in the literature. That also is very important for us, because many times whatever is said and done, we should follow the clinical guidelines. So the outline of my talk would be what is the Rome 4 criteria, how the patient comes, what is the pathophysiology, and different guideline protocols. ISPAGAN protocol, that is the European Society of Pediatric Gastroenterology, NASPAGAN protocol, that is the North American Society, and there is a Indian Society of Pediatric Gastroenterology protocol also. And then we will briefly discuss about standard treatment, what if it is refractory, and anything different we should be doing in infants, and what we should do in the office practice. So these are the three clinical scenarios which are very common to us. A 5.5-month-old girl coming with history of passing stool after 3 to 5 days, and there is excessive crying and straining while passing stool for 45 days now, 1.5 months, and stool which is hard, and there is no other complaints, and on examination everything is normal. There is no delayed passage of meconium. The another case presentation would be the 3-year-old boy, which comes with a typical history of hard stools after 3 to 5 days, which is painful, passes in the standing position, which he has a crisscrossing leg before he goes to the toilet, or he stands at the corner of the room, or he holds the furniture. This is very typical history, which we should not forget that while we are asking. And another case where the 7-year-old boy coming with a history of passing loose stools, and it is a multiple times in a day. It passes in the pants, which is smelly and small amount. And when we dig into the history more, then we will come to know that it is a solid stool. It is not the liquid stool which the child is passing. So these are the three different presentations, and with this we will go to the Rome 4 criteria. So what is the Rome 4 criteria? It is less than 4 years, more than 4 years. So less than 4 years, for 1 month, if the child is having this fewer defecation or excessive stool retention or even painful or hard bowel movement or a presence of large fecal mass, that also constitutes to the constipation if it is less than 4 months. So the previous two cases has fulfilled this criteria. But beyond 4 months, there is something called as a fecal incontinence also. So 2 or fewer defecations in toilet. But if the child has one episode of fecal incontinence per week, which this child was having many, and if history of retentive posturing or a painful defecation and large fecal mass on the per rectal or per abdominal examination, that constitutes a constipation. So these are the definitions which we should be aware about, because many times what I see that the child comes with the loose motion. What the parents say, it's loose motion. But when we dig into the history, it is a small amount solid stool in the pants or underwear, and this is happening for 2 months, 3 months, multiple times in last 3 months, and then we label them as a recurrent diarrhea, but actually it is a constipation. So what are the red flags? So constipation starting extremely early in the life, absence of withholding maneuvers, delayed passage of mechanism, failure to thrive, bilious vomiting or abdominal distension, abnormal neurological finding, developmental delay. These are the red flag signs which we should be asking to each patient, so that we should not miss the organic cause of the constipation. On examination, we should always see that the rectum is empty or loaded with the fecolis. Is there any perianal fistula or abnormal located anus opening? Absent anal or cremastic reflex, decreased lower extremity strength, tone or reflex, any tuft of hair on the spine, or any sacral dimple is there or not. So all these things we should be asking and looking when we are examining these children, so that we should not miss the organic causes of constipation. Why it occurs? There are multiple stressors or precipitors, like premature initiation of toilet training. Nowadays, it is very early. So child goes into the school early, 3.5-year-old, 4-year-old child going to the school, then the daycare. So they wanted to start a toilet training before they put on the daycare. So premature initiation of toilet training. Any drugs or intercurrent illnesses. So child also had a recurrent respiratory tract infection or respiratory tract infection, and then the child has given cough syrup. If the child has vomiting, then given antiemetic. So that also precipitates the constipation. Any dietary changes, like introduction of cow's milk in large amount. So instead of 100 ml or 200 ml, they start with 500 ml, 600 ml, 1 liter of milk intake, or the quality complementary diet. So all of you have observed that the many of them parents come with that key. Yes, he's taking solid, but what solid? So they are mixing the dal and rice from the mixer they are taking, or when they are giving the roti, they mix with the dal and they from the mixie they take out and give. So it is a faulty complementary feeding. Change in local environment. Suddenly there is a travel plan that they wanted to travel from one place to the another place. So they start early morning. So child doesn't go for the toilet. During the travel, they will not go, or when the child goes into that, either whatever the toilet is there, because of the filthy toilet, the child will not go there, and he holds that. And then when he passes after a 40 next day, it is already hard stool. So that leads to a first insult or start of the schooling. So when they start schooling, the child is used to have sleeping till 10 o'clock, but the school starts at 7 o'clock, 8 o'clock, and they rush in the morning while preparing the child, and child is not allowed to go and sit there in the toilet. The psychological factors, it is very important to ask sometimes. A death in the family, any illness in the family, if the child has seen something in the toilet, seen something on the screen which is traumatizing to the child, a death or a massacre or any fight sequence or any character which is known to him getting beaten up in that movie, serial, or any cartoon, that also make a psychological impact to the child. And when he's sitting in the toilet, he start thinking about that and he forget about passing stool. So that is how that withholding and that precipitates it. So by and large, if you see the stressor, infants, it is the top milk introduction of faulty complementary feed. If it is toddler, it is faulty toilet training or excessive milk or junk food. If it is an older child, it is a school or less water intake, because the child is not allowed to go for a bathroom in the school, so they will not drink water for 6 hours, 8 hours, or 10 hours. Increase in the screen time in the older child and in the adolescent. It is obesity, fatty food or fast food, and decreased physical activity. So pathogenesis, what we discussed, is that first insult leads to a hard stool and painful defecation, leads to a withholding maneuvers, and that increases the prolonged stasis, increase in the size and consistency of the stool, and becomes hard. And then again the cycle repeats and repeats and repeats. So we need to break this cycle. So what is the management plan which we follow? Explain the pathogenesis and stressor in detail to the family. Give time and look that what the stressor is so that you can work on that. Give emphasis that it's 3 months duration, and we will discuss about disimpaction therapy, maintenance therapy, and other things. So why disimpaction is important? Because the hard mass which is there in the lower abdomen, which is identified on physical examination on the rectal examination, is obstructing the stool to come freely. So it will, when you disimpact, it decompress the system and it re-establishes the normal pattern, and it prevents the fecal soiling, so that it becomes easy for them to pass later on. I'm just thinking about how to make it only single. Just a second. I'm seeing all these people on the right hand corner. So I just
You
want
just go to right side. There are 4 this hide thumbnail video is there. You can cut short or delete that one. Are you doing on MacBook?
yes, yes.
Yeah, you go to the videos are there now, 4 videos. Go to top of that, just press there. There are 4 columns are there. Hide thumbnail video 1, 2, 3, 4. You can minimize to 0 or you can make it all absent.
I think when we are doing the, I can just do the stop scare and view.
No, right?
So here, hide selfie, hide.
Thumbnail.
And see view, speaker, gallery, hide self view, hide non-video participant.
No. Where you are seeing that or people's faces now, you go and click on top of that. You just share the screen. It is the function of Zoom, not related to screen sharing.
Yes. Yes, now I can see. Yeah. So I will share now. Sorry.
Yeah.
So, so with this information, we should just discuss the drugs and then we will go to the protocol. So there are osmotic laxatives which are used for the disimpaction. One is polyethylene glycol, which comes in the sachet form or in the jar form, powder form. And another is polyethylene glycol solution or the powder, which is 137 gram powder. So at home, if you are disimpacting, then the dose will be 1.5 to 2 gram per kg for 3 to 6 days. But if you are admitting the child, then the dose will be 25 ml per kg per hour orally or nasogastric tube, that 137 gram of the sachet to be dissolved in 2 liters of water. The side effect are loose stools, bloating, and all this. Rectal agents like enemas should not be used for a disimpaction. But if it is to be used, then the saline enemas, the dose will be 5 ml, 10 ml, or 6 ml per kg in the older child, or phosphate soda proctoclysis enema, which is 2.5 ml per kg. So all these have hyperphosphatemia or hypocalcemia as a side effect. But when you are using a maintenance therapy, the dose will be changed. Like osmotic laxatives like polyethylene glycol, the dose will be 0.5 to 1 gram per kg per day in more than 1 year of age. The side effect, remember, bloating, abdominal pain, cramps can occur with this, and loose stool, which we are intended to want the child to have a loose stool. The other group which you can use for the maintenance is disaccharides. So either lactulose or lactitol. So the dose of lactulose will be 1 ml to 2 ml per kg. So less than 1 year it is 2.5 ml BD, or more than 1 year it is up to 10 ml, or more than 5 year it is up to 20 ml. If we are using lactitol, the dose will be 250 to 400 milligram per kilogram per day, which is again almost it comes to 1 ml per kg. So 15 ml is 10 gram of the lactitol. So in the lactitol or lactulose group, you will have more of abdominal distension and discomfort. The other group which we use is a stimulant laxatives like bisacodyl or sodium picosulfate. So bisacodyl is completely contraindicated in the children, and sodium picosulfate can be used, but it is contraindicated in setting of proctitis or when the child has gaseous abdominal distension or a impacted stool. So stimulant laxatives should be used as a rescue therapy, and the dose of sodium picosulfate is 2.5 milligram to 10 milligram per day, and more than 4 years you can go up to 20 milligram. The syrup which is available is 2.5 milligram per 5 ml or 5 milligram per 5 ml. There are two syrups which are available. So with this, what are the we will go to the protocols. So what are two protocols or three protocols we are aware about? One is Ispagan and Naspagan protocol for treating constipation. So this is the protocol for less than 6 months. So I will go to this first protocol. So when the child comes with the constipation, when the child is 6 months or less, look for alarm signs and symptoms like what we discussed about red flags. If the red flags are present, then go to that specialty. So if it is a pediatric surgery related like anterior place annus, or you're thinking about Hirschsprung, or you are thinking about annus stenosis, that will go directly there. Or if there are neurological, then it will go to the neurologist. If it is something like that, we will come to know in a minute. So I will talk about something one more extra here. So if the alarm signs are not present in less than 6 months, look for that is the child exclusively breastfed or top milk has been given. So if the child is exclusively breastfed, then probably it is a normal variant that the child is passing in 3 days or 5 days, and you should evaluate that child after 2 to 4 weeks. But if the child is not exclusively breastfed and there are no alarm symptoms, then you label them as a functional constipation. And the treatment would be education, diet, so verify that proper formula, proper dilution has been given. And if that is troubling the child, then you should change this formula, because sometimes we have the milk allergy presenting as a constipation in this age group, and ask them to maintain the diary. If the treatment is effective with this diet and then if it is not effective, then just give oral medication. So what is the oral medication which is allowed in less than 6 months? Is the lactulose or lactitol. Okay. Occasionally suppository to be used. It is not that daily suppositories is given to this child. If the treatment is effective, then maintenance therapy to be continued. And if it is not, then again reassess the adherence, re-education. And if it is not making the effect, then refer. Maintenance therapy, how many days we should be giving in this Naspagan and Ispagan guideline? 2 months continuously. If the child is passing normal stool, then and then only you are going to decrease the medication and taper and then stop. So this is clear. So what if it is more than 6 months? This is very busy chart. So I will just discuss this part, which is very important for a pediatrician, because beyond this, it is something which is for the pediatric gastroenterologist or the specialist to look into. I will come back to this chart again. So if the child is more than 6 months, so again, constipation, look for red flags. If yes, then evaluate further or refer to the specialty. If it is not the red flag, then label as a functional constipation. And after this label, beyond 6 months, look for fecal impaction. I think we as a practitioner are not giving importance to this fecal impaction. So if the fecal impaction is there, then disinfect with oral preferably or sometimes rectally. And then if the treatment is effective, then go to the education, diary, toilet training, and oral medication. So this is a maintenance therapy. So for this impaction, we have just listened to that first slide. Polyethylene glycol is the preferred drug. It is to be given either orally or administered through the nasogastric tube if the child is not taking and it is very bad fecal impaction. The dose is 1.5 gram per kg. So 10 kg child, 15 gram will be the dose. For 20 kg child, 30 gram will be the dose. So the dose is very important for disimpaction, and that to be given for 3 to 6 days. And then you start the oral medication for the maintenance therapy. So evaluate after 2 weeks. If the treatment is effective, then yes, then continue the maintenance therapy. That is, if you are using polyethylene glycol, the dose is 0.5 gram to 1 gram per kg. So for us, a 15 kg child, if it comes to us, then the dose will be 10 gram to 15 gram of polyethylene glycol. So we need to calculate that what we are prescribing. Is it a jar which we are prescribing, or is it a sachet, or is it a liquid? Because liquid 25 ml contains 13 gram. A sachet will contain 17 gram or 8.5 gram. If we are using the jar, the 1 scoop will contain 8.5 gram. So we need to calculate that and give effective drug and effective the dose. If the child is not responding, then reassess is the adherence is there, re-educate about the other things like diet, fiber intake, water intake, see that different doses is needed or not, see that if the child needs a different medication. Sometimes the child is not taking that 200 ml or 250 ml of water, then you need to change the dilution effectively, or you change the prescription to the drug which will have a less dilution. Consider the untreated fecal impaction. So whenever there is no response or a loss of response, then think about fecal impaction. This is very, very important. And that is the beauty of this flow chart. Why I am showing this is the Ispagan and Naskagan. If there is relapse, again, go back to the reassessment. And if the treatment is effective, continue the maintenance therapy. How long to continue the maintenance therapy? Till the child passes normal stool daily for 2 months without any pain, without any difficulty, and sitting on the toilet. If that is achieved for a 2 months, then you start tapering the medicine. And then the taper should be slow, gradual, with proper follow. So this is in brief about the more than 6 months. So I have taken out the major part of it. So I will go back to the chart. So right hand corner, lower corner, you see, if the patient is not responding, then think about differential diagnosis. So what are the differential diagnoses? A celiac screening, thyroid, and consider other cow's milk allergy, which we consider in less than 6 months also, more than 6 months, up to the age of 2 years. Okay. If the results comes positive, then treat accordingly. If the result comes negative, then doubt about the diagnosis of constipation if the child is not responding. Or if you have a no doubt, then label them as an intractable constipation where it comes here. But if you have a doubt about constipation, functional constipation, then what the next step would be the colonic transit studies. Confirm the constipation, manage like constipation, like intractable constipation. And if you found it is intractable constipation, then you think about Hirschsprung, anorectal malformations, or a spinal malformations. Work up for that. If normal result, then colonic manometry is something we should be doing it to rule out the coronary neuromuscular disorder. And if all these are things normal, then consider biofeedback, which is very, very important. Sometimes adolescent coming with the constipation, they don't respond to the normal. They need biofeedback. They need ACE, very rarely, antegrade continence enemas. So we take out the cecum out or appendix out, we put the cecostomy or a gastrostomy tube there, and antegradely we do the enemas, not retrogradely, because it is not going to be effective. So your colon should be empty in the morning, or you try Botox. SNS is sacral nerve stimulation. TNS is transcutaneous nerve stimulation. If it fails, then consider surgeries or a pseudo obstruction syndrome. So this is how we approach or treat constipation as per the ISPAGAN and NASPAGAN guidelines. Mind you, this is very, very difficult to read, understand, and do. So we as an Indian society came up with the very nice guidelines in 2018. So these are the ISPAGAN guidelines. This is very simple to follow. Not less than 6 months or 1 year we have taken. Anything more than 6 months, if it is a constipation, look for red flags. If present, think about organic and manage accordingly. If it is absent and you are thinking about functional constipation, then see for fecal impaction. And how do you confirm fecal impaction? There are 3 pointers to it. One is if the child is having soiling or incontinence, that more or less confirm that this child is impacted. Okay, or if you do the rectal examination and you find fecolith in the rectum, then you know that there is fecal impaction. Very rarely when we are not able to confirm it, then particularly in the developmental delay child or mentally retarded child, where doing PR and doing these things are very not possible, then sometimes we do the X-ray to see the fecal impaction, but it is not the routine thing. So when there is a fecal impaction, you disimpact. Hospital base, which we discussed, 25 ml per kg per hour of polyethylene glycol with electrolyte, that is 137 gram dissolved in 2 liter of water, which is rarely needed nowadays. Home disinfection is equally effective. The dose in European society was 1 to 1.5 gram per kg. In Indian society, the dose is 1.5 to 2 gram per kg because we need a higher dose. So a 20 kg child may need 40 gram. A 10 kg child may need 20 gram of polyethylene glycol for disinfection for 3 to 6 days. And then you maintain on the laxative. Prefer to give polyethylene glycol more than 1 year of age. And then reassess on the follow-up response, compliance, and dose titration depending on how much stool the child is passing. So the expected or desirable is 1 to 3 stools per day without any dehydration. But if you have a reimpaction, then again you need to disimpact. And if there is an inadequate response, then you need to increase the dose. Or if there is no response, then change the medication. So when you are changing the medication, or if you are adding the medication, don't add too osmotic laxative. So if the child is already on polyethylene glycol, don't add lactulose or lactitol. So it should be a stimulant laxatives, and the stimulant laxatives to be given for very short duration. If there is good response, continue, give it for 3 months, and then gradual weaning. Successful outcome, gradual weaning. If there is no relapse, then stop medication and follow up. If there is relapse, then again go back and see reimpaction is there and then treat. So I think this is much clear, better, and easy to understand what the ISPAGAN and NASPAGAN guidelines are given. So these are the two protocols which are we usually follow. So with this, the few slides on the diet: encourage the breastfeeding, continue the cereal supplementation after 6 months of the age, adequate intake of water, reduce milk, dairy products, soft drinks, or the bakery items, avoid the junk foods, and give good amount of fiber. So what are the fiber-rich foods? Lentil, peas, potato with the skin, blackberries, dates, pear, guava. These are all fiber-rich. So this is the pictorial presentation which I took 10 years back. The 100 gram of fruit gives 2 to 3 gram of fiber. 100 gram of your carrot, cucumber, beet, or radish will give again 4 to 6 gram of fiber. A simple 50 gram of green leaf vegetable gives 2 to 4 gram of the fiber. Spinach is very rich in the fiber. So last, what we should be explaining to them about the toilet training, but it should not be beyond before 24 months of age. Recommended age is 2 to 3. Rule of 1: toilet training to be done by one person. The toilet should be the same. The only one toilet should be used. One routine, that is 5 minutes after each measurement. One place, one word. Should not be confused with multiple words. And it should be 5 to 10 minutes unhurried time in the toilet. And preferably squatting position. If it is a Western toilet, then stool should be given for the resting the feet. And there should be positive reinforcement or award given to the child. Okay. What if child not responding? Reassess again the drug compliance. Check for the diet and enough fluid, whether child is toilet trained properly or not, and reassess that are we missing any organic cause of constipation. So when do you say it is a refractory constipation? So constipation not responding to your optimum conventional treatment for at least 3 months, despite a good compliance. So in spite of your good counseling and all the things parents has done, the problem is still persists. Then you think about this. Are we missing Hirschsprung? Are we missing hypothyroidism, hypokalemia, hypercalcemia, celiac disease can present, milk allergy can present, anal achalasia, colonic inertia, anal stenosis you have missed not doing the PR, any lead poisoning, or very rarely you have pelvic mass, spinal cord abnormalities, because of prune belly or gastroschisis, there is abdominal musculature which is abnormal. So you will find difficulty in managing them, or you have a pseudo obstruction, something which is visceral neuropathies or myopathies which runs in the families, or you can have multi-MEN endocrine problem also. So how do we investigate them? We have the armamentarium of anorectal manometries, barium enemas, suction biopsies, colonic full thickness biopsies, colonic transit studies, MRI spine to look is there tether card or any problem in the spine. Sometimes Arnold Chiari also comes with these problems. Colonic manometries is something which is done in very few centers, or you do the colonic scintigraphy other than the colonic transit studies to look for the what is the transit time of the colon. Do this blood test also if it is refractory, thyroid test, celiac test, TTG, calcium and potassium. So what are the treatment options when we are having this refractory constipation? We have the armamentarium of drugs like lubiprostone, linaclotide, prucalopride. Plenty of my patients are there on this drug. We have the options of antegrade continence enemas, which is a surgical option. Something which is sacral nerve stimulation or transcutaneous nerve stimulations are available in Pune and Mumbai. And in anal achalasia or a very short segment Hirschsprung in older child, we have the endoscopic treatment of per-rectal endoscopic myotomy in these children. So to summarize and conclude, the constipation is very common. A simple history and physical examination will be sufficient to label them as a functional constipation. Think about fecal impaction. It is very important for a practitioner to think and disimpact those patients before you start on the maintenance therapy. Sometimes your maintenance therapies may take up to 6 months. Less than 1 year, we prefer lactulose and lactitol. This is according to the ISPAGAN guidelines. More than 1 year, polyethylene glycol. Diet, laxative and toilet training. All these three armamentarium should go hand in hand. And if effective, then taper and stop over 3 months. Thank you. Kundan, you are mute.
Kundan sir, kindly unmute yourself. Kundan sir, you are on mute.
Yeah. Thank you, Vishnu sir, for providing a comprehensive overview of the topic. And your case-based approach greatly assisted pediatrician in making connections and understanding the topic thoroughly. There are some questions that are in chat box. So I will ask you that question. Dr. Daksha madam has asked, what is the maintenance therapy for constipation and how long it is safe?
Maintenance therapy for constipation is either we use polyethylene glycol or
तेरे का तो दलियो भी है खिचड़ी में भी कोई तब तो बन रही है दाल खिचड़ी
अरे हाँ वो
I think we need to mute. Yeah.
yes
Yeah.
sir.
So maintenance therapy is either with the polyethylene glycol or a lactulose or lactitol. The dose which we discuss is 1 gram of polyethylene glycol per kg, or if you are using lactulose 1 to 2 ml per kg twice a day. If it is a lactitol, it is a 400 milligram per kg and 10 gram per 25 ml. We should remember the dose of lactitol. The polyethylene glycol 3350, 4000 both are effective. So all can be used. The minimum duration is 3 months. And during these 3 months, we expect the parents to make an effort that the diet is good, the water intake is good, the toilet training has been established, and that fear of not going to the toilet has already been taken care of. And then when the child is passing on the daily basis without any problem for at least 2 months, then you start tapering the dose. So sometimes it takes 3 months, sometimes it takes 6 months, and some of the patients, like we have the autism spectrum disorders, neurodevelopmental delay patients, they need a maintenance therapies for years together. Some of the children are there on these laxatives for 2 years, 3 years, 4 years, and these are safe, except some few can have abdominal distension, bloating, or flatulence that can be taken care with the switch or the other drug.
The next question, I think you answered. What is 3350 or 4000? Which has to be preferred?
The 3350 you need to dissolve in certain amount of water. 4000 you don't need to dissolve it. So ready-made 25 ml of 4000 can be given directly without a dilution, and the 25 ml contains 10 gram of polyethylene glycol. In 3350, 25 ml contains 13 gram. So that we should be remembering, and that needs to be diluted further.
And below 6 months, exclusively breastfed babies sometimes passes stool after 7 or 8 days also. Then what is the definition for constipation in these babies and without any red flag signs?
So
Below
that
6
is what they said. If the child is on the breastfed and if the child is passing after 3 to 5 days or 7 days without having any trouble, no pain, no bloating, no distension, no excessive crying, no fissure, then we should not treat them. So we should not label them as a functional constipation. This could be a normal variant of normal children.
any role of suppositories? Most of the common people commonly use Halens and they are used. What is the role of that? Any evidence?
Suppositories are only in very badly impacted children where your oral medicine is going to fail. So then only we use, or if the child is coming middle of the night at 2 o'clock with excessive crying, and you know that the parents are giving the history of constipation for last 1 month or 2 months, and that time to relieve that pain or that symptom occasionally can be used,
Not routinely.
not routinely.
Yeah. And what should be the indication for admission for fecal disinfection?
Okay. If you see a visible peristalsis, distended abdomen, and you can palpate a hard lump, which is a big, which you think that just by giving the oral medicine at home will not be sufficient. So for them, you need to admit these children.
There are some questions regarding these drugs. Any role of sodium picosulfate?
Sodium picosulfate is a stimulant laxative, should be used for a shorter duration. It is not to be used as a maintenance therapies for a longer duration.
Then any role of senase of these tablets and ispagol?
Again, yeah, Senasoft again a stimulant laxative. These are only to be used very for short term duration. So let's see if the child is on the osmotic laxatives for last 15 days, 20 days, was doing okay. But again, after 20 days, he's coming with that key, 2 days he's not passed. So the optimum dose you are giving. So you have to add a stimulant laxatives for shorter duration. So there is a role of the sodium picosulfate. Other than that, no.
Any role of X-ray abdomen?
When you have a doubt that the child is impacted or not, and you are not sure, and the PR is not possible because of cultural acceptance or parent is not accepting, and a child which is not cooperative for PR examination, or then only we do the X-ray. But I think once in a year we do the X-ray, so it is not the routine thing to do.
And gradual weaning of peg. Please explain how to titrate.
So what I personally do is over a period of 1 month. It is not over a period of 1 week or 2 weeks. So 3 months of your polyethylene glycol, if you are given, let's say 20 kg child, you are given a 17 gram of your polyethylene glycol. So what I will do, so from 17 gram, I will make a 8.5 gram for next 1 to 2 weeks. And from 8.5 gram, then I will make alternate day and then stop. And after stopping, tell them that you have to come back after 1 month to see that you are doing okay after stopping or not.
And there are many questions regarding dietary suggestions in OPD practice. Most of the patient comes in OPD. You are a busy OPD. You have to give dietary suggestions, and they are asking many questions like, should I give this? Should I give this? So a bullet answer to them. This is to be given. And when it are asking regarding fruits, which fruits to be given specifically and which fruits to be avoided.
Okay. So people have this myth of avoiding certain fruits. So I don't think any scientific basis on that. So all the fruits can be given with the skin of the pulp. So what that photograph which I have shown. So if you give these 3 group of food items, like a vegetable, 1 fruit, and 1 roots and tuber, that is usually sufficient to meet the fiber intake of the child. What needs to be avoided is particularly the fatty foods. Like we always forget fatty foods. We never realize that the milk is also fatty. So 100 ml of milk gives 5 to 7 gram of fat. 200 ml it is double. Sometimes 500 ml of milk it becomes 35 gram of fat. So we have to stop the fat like milk and paneer, cheese, and ghee particularly, and make sure that they get a good amount of oil, and no junk foods, no packet food. So only 4 5 things if you can in the busy office practice. I know that if you tell them that strictly know this and please give this, then probably you are giving the right answers in the short time.
Yeah. And what is the how to prevention of constipation in children? Guidelines in Indian scenario.
So if the good complementary feeding is there with a variety of food, what we say, there are 8 food items and at least 5 food items should be given on the daily basis, and there will be rotation of that food item. Then I think with good complementary feeding and good water intake, the constipation may not occur. And I was just discussing with my colleague today that if we see a constipation, or maybe I am biased, but majority of them are the males because they are pampered and they are given liberty of doing all the things which are not given to the female, and that is why females are never that much constipated in our office practice also. So I think that pampering and this thing also needs to be curtailed down by the parents. That may improve.
Any role of probiotics in treatment?
At present, no.
Any role of castor oil, seeds bath?
Castor oil, strictly no, because we have good drugs now. So there is no need of giving castor oil. Seeds bath only in patients where you can see visible anal fissure or there is a perianal pain. Then we advise them seeds bath also.
Fissure in or associated with
Fissure,
them.
yeah.
Any role of psyllium husk?
No.
And there is one question. This one says that ideal age of initiation of toilet training. When to start?
It is after 2 years of age. Too early can damage and make problems. So the other point is the child should be developmentally capable also. So he is standing, sitting, he is walking, and he can able to sit in the squatting position. So that is the prerequisite for the toilet training.
Yeah, this many parents use suppository
Kundan.
whatever they feel their child is constipated. Can that lead to long-standing problems? Suppository use.
Suppository use has two problems. One, they will only disimpact the left side of the colon. So they will not disimpact total colon. So they feel that they have given the treatment, but it will not be adequate. Second major problem of rectal suppository that it adds to the fear. The child is already having the fear of passing the stool, and you are forcefully inserting the suppositories, and that adds to the fear, and the treatment failure will be much more with the use of suppositories.
Yes, sir. Ram Gopal, sir.
Yeah. Sir, I just wanted to know one thing. You said that milk causes constipation. Now it is actually other way around. The parents comes and they tells the milk is causing diarrhea. So it is difficult to understand whether the milk causes constipation or whether milk causes diarrhea.
Excess milk definitely causes constipation because the allowed milk is in breastfed child only 100 ml or 200 ml extra milk is allowed after 6 months of age because it contains lot of fat. Fat itself can lead to your decreased transit time, and that one more problem with the milk intake is that if the child takes milk, he will not eat, so there will not be any fiber intake also.
And I agreed, but so many times the parents comes whenever we give top milk, there is a loose motion. And it becomes really very difficult. As you said, even we try to tell them there is no fiber in the milk. So we tell them, okay, reduce the milk quantity. But this usually happens. Second question is ki now normally we say banana is very good in constipation because it has got a lot of fiber also. But as soon as you advise banana, the next questions come, it causes a cold or cough to my child. So what is the any answer to this? Because this is a universal problem.
Yeah. So something is called as a oral food pollen syndrome, and something which is called as a histamine present in some of the fruits. Histamine releasing substances which are present in the fruit. So if it is a really worrisome, like child goes on the inhaler and it causes rash and there is a problem and difficulty in breathing, then yes, it should be avoided. But it is very, very rare. But as a routine, it is a myth. So we need to just demystify the myth.
Okay.
Dr. Ramakant, sir, I want to ask some question. Dr. Ramakant, sir, I unmuted you.
Yeah, thank you, Kundan. Wonderful presentation, Vishnu, as usual.
Thank you.
What is, how do you diagnose and treat ultra short segment Hirschsprung?
Yeah. So ultra short segment Hirschsprung, sometimes it just behaves like a functional constipation. So after 3 months of your treatment, and when you have started tapering or when you stop, and again the child develops the constipation, then you think about ultra short. But there are certain subtle signs which will be there. Usually in Hirschsprung, the fecal incontinence is not there. So if the child never had a fecal incontinence and the you think that it is a very badly impacted stool, then you think about a ultra short segment Hirschsprung. Second, when you do the parectal examination and you find that anal is very tight, the sphincter is very tight, then you think about ultra short. And we have the armamentarium of anorectal manometry. So when I think about or when I suspect it, so after disimpaction and treatment of constipation, I do the anorectal manometry, and that usually gives me a clue that is it ultra short or not. But ultimately, sometimes we need to do the colonic either suction biopsies or a full thickness biopsies.
But where will you take the biopsies? After anal manometry, you will decide.
After anal manometry, it is from the dentate line, we take that core of 2 to 3 centimeter,
And
deep core.
is it necessary for us, or it is your domain to decode this thing about what we call it as a slow transit constipation and rapid transit constipation, normal transit constipation, not rapid, slow transit
Yeah.
constipation, particularly where everything will fail.
Yeah, it is very difficult to treat, and it is not straightforward. So I think there is lot of things needs to be discussed when we are treating the slow transit constipation. I think it will be very confusing. But what we do is we do the transit studies by the markers and a manometry, anorectal manometry, and we treat them with the stimulant laxatives, like not like only sodium picosulfate, but prucalopride is very good drug, and at least 3 or 4 constipations families are there which are following with me since last 4, 5 years, 7 years now, and they are on these stimulant laxatives like prucalopride. Only once I have to do this ACE surgery, antegrade continence enema therapy surgery,
Through appendix, shayad,
through a cecum they have done.
cecum, appendix or
Yeah.
cecum. And whether this prucalopride and lubiprostone is available in India, and it is
I
again your
remember the first patient which I started was in 2011 or 12. So that time it was not available in India, so we have to procure it. But I think 2016 it has been readily available now. There are
more
plenty of pharmas
Yes.
which are having this prucalopride.
Now, I think
One last question from me, Kundan, about you must have spoken about fiber, whether I might have not heard it. And second, this thing is to that is soluble fiber and solid fiber. So, are there any soluble fiber particular fruits you will? Because we say that in pear and apple, pectin is more, which will be forming stools more, as somebody has asked it. But which are the soluble fibers, and what is the role of commercial fiber preparation available from pharmaceuticals?
So the commercial fiber formulations which are available are there with the lactulose or lactitol or with polyethylene glycol also. They are being used particularly in those patients having pelvic dyssynergia. And this is very common problem in adolescent, and where probably your osmotic laxatives may not help. So there we use it, and commercial formulations are available. So we use up to 20 to 40 gram of commercial available fiber. The soluble and insoluble fiber, every food item has the both the component. Some of the food have more of soluble fiber, and some fruits have a more fruit or the food items have a more of insoluble fiber. So depending on is it a slow transit constipation or is it a normal transit constipation? If it is a slow transit constipation, we try to decrease the fiber intake, and we don't want insoluble fibers at all. At all, if the child is taking, soluble fibers are allowed there. In normal transit constipation, we have to give a adequate amount of fiber, not excess amount of fiber. So that is why we don't recommend to give the commercial formulas.
I will ask
Thank-
some basic question in the chat box. What should be
Okay.
the recommended daily water intake?
It is the same. 1 liter for 10 kgs and for 20 kg it is 1.5 liter.
And there are one question, PEG sachets which we dilute supposed to be used within how much time?
1 to 2 hours is okay.
Yeah. And what about diluted PEG we get ready-made formulations?
That is okay to use.
Okay to use.
Yes, yes.
Yeah. Now there are some super specialty questions like what is the role of MRI echography? Then some want to speak about encorporesis. Any other diagnosis other than misconstipation?
So encopresis are the three uh, problem. Two types we say, which is a primary encopresis or secondary encopresis. So in the secondary encopresis, it is always a small amount which comes out. If it is a large amount which comes out, that means there is a problem with the sphincter. If it is a small amount which comes out, it is usually secondary to the constipation. So whenever you have an encopresis or incontinence or a swelling, then the best treatment would be the disimpaction. So if your oral disimpaction fails, then that what we call as 137 gram in 2 liter of water and give 25 ml per kg per hour orally for 4 hours. So that will help you in achieving the disimpaction and the encopresis goes away. If it is having a because of some disease, like sometimes you have a tethered cord, or sometimes you have a Arnold-Chiari malformation, then it becomes a difficult task. Sometimes these children needs to go for a spine surgery also. And regarding MRI difficography, yes, that difficography is available in Pune. We do, but that too only for the pelvic dyssynergia in the older child, because you need a specialized chair and you need to sit there and then do the MRI and see that what is happening. So many times we can see the prolapse of the anterior wall of the rectum. Sometimes the levator ani getting tight, and many times there is a propulsive pressure of the rectum and abdominal muscle which is lacking. So depending on which area is deficient and defective, you need to target oriented therapy should be done in those children.
Here I want to ask one basic question. Now these questions are coming like for super specialty. As a common pediatrician, when should I refer patient of constipation to specialists like you?
I think it is very clear. The red flag sign, if they are there, failure to thrive, anemia, big abdominal distension, or not only pediatric gastroenterology, but if you have abnormal neurological examination, needs to be referred to the neurologist. If you feel that there is a umbilical hernia, child is slow, child is delayed, there is skin which is this, then you should refer to endocrine by doing the thyroid function test. If your child, after giving a proper treatment, proper advice, if they are not getting a result after 2 to 4 weeks, then they need to refer to a specialist for a proper guidance, because it takes at least 15 to 20 minutes to explain the pathogenesis and everything. And then from our side also, we need to take the help of dietitian, because there are like today, within 1 minute, we cannot say everything. So we need a proper time of 20 minutes, 30 minutes, 40 minutes, and then tell them and explain them on the practical basis that what diet needs to be changed, what is the stressor, what the family needs to do. So if we tell that in advance, in detail, over a period of time, the response will be there. So in refractory cases, yes, after 2 to 4 weeks, if the child is not responding at all, then they needs to be sent to the specialist.
Yeah. Any specific guidelines for spinal dysraphism for CPs and neuromuscular disorder patients?
In CPs, I find difficulty in giving the lot of fibers. So we need to give juices. We need to add something like almond or powder in the milk, and really they need to properly disimpact, because they are very badly impacted. So sometimes we need to give stimulant laxatives along with in between when there is a in between if they develop the constipation. These are the very different and difficult subset to treat. Means in spite of doing all, majority will not be able to do that because they need to take care of the physiotherapy, they need to take care of this child and their routine. So for them, if we say lot many things, it will not be possible. But one intervention has really changed is putting the gastrostomy tube in the cerebral palsy or neuromuscular the mentally retarded child, and that has really helped for the parent to get rid of the constipation, to get good care, give that time for the physiotherapy instead of just taking 40 minutes or 50 minutes for just feeding. So it becomes easy for them to feed, give medicine. So gastrostomy tube in these children really helps.
Regarding toilet training for toddlers, which toilet design one should prefer? Indian design, Western design, or any will do?
Any will do, as long as child is
As
comfortable
long as
with.
the parents and these are comfortable,
Yeah.
that
Only
best.
Western toilet, you need to give something for feet to rest. Some
Okay.
stool should be given. Yeah.
Yes. And alternating constipation with diarrhea, how to approach?
So majority times it is the fecal incontinence or soiling of the stool. So when you properly disinfect, what we call as a spurious diarrhea, we
Yes.
have to develop the terminology of spurious diarrhea. So they should be given disinfection.
And what are the complications of self-evacuation in adolescents about which they do not disclose to pediatrician and parents?
Yeah, very important. So these are the children which having a pelvic dyssynergia and they go on developing solitary rectal ulcer syndrome. And this solitary rectal ulcer syndrome is again a misnomer. So it is not solitary, it is a multiple. It is not limited to rectum. Whenever there is an inflammatory reaction start, it goes up to the sigmoid. It is not the ulcer. Sometimes it is a polypoidal masses like a polyp they develop, and it is very bad disease to treat, and they undergo lot of endoscopic surgeries or interventional surgeries by the pediatric surgeon. So what we need to do is keeping the toilet time less than 10 minutes, taking them that no straining is required. And these are the subset where your anorectal manometry will help, not only in the diagnosis, but in the treatment also. So what we call as a biofeedback. So while doing manometry, we train them in such a way that they will learn themselves how to relax the sphincter and how to make that propulsive force so that they will not fail while passing stool in the toilet.
Can constipation be a sole symptom of CMPA?
Yes.
Okay, there are many questions. I think this is the first time that talk and question and answer time is same. And there I have covered most of the questions in the chat box. Some are repeated questions like a role of any natural like Sena, lukewarm water to be given. These I think we have answered. The constipation in newborn period, I think we have answered this one also. So thank you, Vishnu, for
Thank you.
giving
Thank you.
collaborative talk and covering all the questions. And now I will like to thank all the people who has contributed for this successful contribution. Most importantly, Vishnu, for giving time in his busy schedule
Thank you.
and covering the topics so well. Then I will also like to thank Dr. Ram Gopal, sir, President, and Secretary Dr. Amol Pawar, and also Dr. Bhavesh Mithya, Scientific Convener for MyIP, for choosing this topic. Such is the important topic that almost after 1.5 hours also almost more than 200 people have joined. They are connected and asking questions continuously in chat box. I will also like to thank all OBs and EBs who has joined this seminar and also asked and taken active participation. And I will also like to thank Vishal Raut, Dr. Pallavi Madam, for giving the technical support for this webinar. And most importantly, I would like to thank all the pediatricians who are busy in their OPD practice for joining at right time and connected throughout the session. And also, I would like to thank in advance to those who will join and see this webinar. in MahaIP platform, which is available on our MahaIP YouTube channel. So I thanks all. Bhavesh sir, do you want to comment anything?
No, excellent session as usual. Thank you, Dr. Berada.
Thank you, sir. Thank you. Thank you,
I will just check
Amol.
any questions are there. Yeah, we have covered almost all the questions.
Amol has left.
Yes, yes.
He's traveling.
Yes, yes, sir.
Okay,
Ram Kumar
thanks
sir,
everyone.
anything comment?
Yeah. No,
Yes,
no,
thank you.
excellent
Thank you,
session
everyone.
as usual.
Sir, with your permission, should I close the meeting?
Yes, yes, yes. Okay. Yeah.
Thanks and good night.
Thank